I was diagnosed with 2A Hodgkin lymphoma in 1986. I was a student nurse in London, and I had radiotherapy, high dose, and then went on to have chemotherapy. And then when I finished my nursing career, I moved up north to the north of England, and I signed up with the Christie Hospital, which is a famous cancer hospital in Manchester, in the north of England. And they had, I knew this already, a late effects clinic. So I referred myself, and this was all during lockdown. And I had 2 telephone consultations with the Professor Radford, and we got on. And during COVID, he asked me to take part in an online conference about living with and beyond cancer for the Greater Manchester area. And that was quite nerve-wracking, but it was quite an honour, and I rose to the occasion, and it was good. I really enjoyed it. And I think that it was on the back of that he approached me, and would I like to come to Germany to the International Hodgkin Lymphoma Symposium at the end of October last year. And my brief was just to give a patient perspective on having, well, that's all he said, patient perspective, and that I had to speak for 10 to 15 minutes. So big breath. He didn't tell me anything else, so I didn't really know what I was meant to be talking about, but I gave it a great deal of thought. And I thought, how do I feel? How did I feel at the time? How do I feel now? But most of all, what did I actually want to say? And to kind of get back into the zone, I read my diaries. And when I was poorly at the age of 21 and 22, I had treatment for a whole year. I wrote diaries, 2 diaries. So I read 1986 and 1987, and it was mainly about boys, as you can imagine. But there's quite a lot about my treatment as well, but not an awful lot. I was way more interested in boys than I was in chemotherapy and radiotherapy. Believe me, there was a different one on my mind each week. And I thought, they don't need to hear about this. And even though that I'd really like to share it with somebody one day, I knew it wasn't the right place to share the content of my diary. So then I thought, what do the clinicians want to hear? And I reckon they probably wanted to hear about my late effects and what had been wrong with me in the decades beyond my treatment. And that's how I approached my talk. I said what happened in the first decade, the second decade, the third decade. I think actually we're on the 4th decade now. I'm 30. Well, it doesn't really matter. I can't do maths. And so that's how I formulated my talk. And I spoke to them about my late effects. And then I thought at the end of my talk, I'm going to talk to them about what they need to hear. Because I know that they want to hear about late effects, but there were a lot of things that I need them to know. So that's where I began. So I told them about the late effects. I told them about my thyroid packing up when I was in my 30s and going on to thyroid replacement. I told them about my heart issues during my 40s and my 50s. I told them about my breast cancer. I told them about my lung function, etc., etc. And you all know all the things that we're having to cope with. I gave a shout out for Hodgkin's International because I feel that's very, very important for, any survivor of Hodgkin's lymphoma to have access to that. And people wrote that down. And it was actually mentioned in the summary as well. So when they summarized my talk, they definitely took note of that. And I thought that was wonderful. But more importantly for me, I wanted to tell them that emotionally it was becoming harder, and that during my 20s and my 30s, I kind of sailed through all the late effects. Hypothyroid, easy. It was a doddle. Screening for breast cancer, a doddle. Breast cancer, copable with. It was okay. It was fine. Certainly didn't really shed a tear. But now I'm getting towards my late 50s, and I'm beginning to realise that I'm just not going to last as long as some of my friends that didn't have lymphoma. My heart is beginning to struggle. My lungs are beginning to struggle. When I get a cough, it's just a nightmare. I just cannot cope when I get a cough. It becomes panic stations. And I wanted them to know that I'd actually had counselling for the first time. Not many sessions, to be honest, but I've had counselling in my 50s because emotionally it's getting harder. And I know that I'm not going to live as long as my best friend down the road, who's the same age as me right now. And that's kind of quite sad, really. Well, it's very sad for me, for all of us. And I think that I've developed, and I don't know about anybody else because I can only speak for myself, but I've developed this personality that is strong and, I've coped well with everything. And everyone says, not everyone, but people say, you're strong, you've done so well, you're inspirational, you're wonderful. But behind that veneer, and I think I use that veneer not to get good care, but I know that good communication gets you further with health professionals, as I know this, than being quiet and shy. I've developed this personality to help me cope. But beneath that personality is somebody who's quite sad, and I'm really, really grateful for what they all done for me. I'm so grateful to be here, but I'm also scared of what's going to happen next. And I asked the professor that I see, I've had all this wrong with me in my 50s. What's going to happen in my 60s? And he said, more of the same, and your heart will get worse. So, yeah. So that was that. That was the talk. And then the reception, i.e. how it went down, was phenomenal. So I'd been the first person ever to talk at this symposium. Not the first person, the first patient ever to talk at this symposium. And there were 3,000 delegates. They may not have all been there, but it was pretty busy. And I was like a mini celebrity. They wanted to come and talk. Thank you so much for your talk. It was so interesting. I think that clinicians, they treat disease, but seeing a person, and a person that has recovered and is living with the late effects, they don't like the term survivorship, was really great for them. It was really great. So that was wonderful. And I learned lots. So I'm not going to tell you what I learned. And I'm not going to tell you everything that I learned because I can't remember, but I'm going to tell you the most pertinent points. So what I learned was that women who went through high dose radiotherapy, as we know, had a higher risk of breast cancer. And I think they thought that when they reduced the dose of radiotherapy and they targeted more, so I had mantle feel, so it was all over here, all over my chest, all over my back, it seemed like the whole of my upper body was irradiated. But now they target it on the tumors themselves, but they're still getting increased cancer, in breast cancer. Not as much as in my cohort, but it's still there. So it's not quite the effects they thought. The other thing I didn't know much about, because I'm not a smoker and I never have been, is that I'm still at risk of lung cancer, and it's about a 1% risk. And was I shocked? Maybe a little bit shocked by that. It's certainly not far from my mind. And in Manchester, they are doing research on starting screening for people who've had high dose radiotherapy to screen them for lung cancer. I met some marvelous people, absolutely wonderful. So we had a speaker's dinner on the Saturday night, and I met a wonderful clinician from Boston Children's Hospital, Massachusetts. And what was interesting for me about what she had to tell me was that in Boston, in the pediatric department, they treat you from 0 until you're 25. So she gets the young adults in the pediatric hospital, in the children's hospital, which I thought was very interesting because I was treated on an adult ward. So I was surrounded by, old ladies when I had my chemotherapy. And I asked her, what is the hardest age to treat? No, first of all, I had said, what is the best age to treat? And I didn't mean in terms of, clinically, I meant emotionally. And she said, the best age to treat for lymphoma is 10 years old. Because at 10 years old, you're still with your parents, Your parents make all the decisions. Your parents are looking after you. And it makes the doctor's job a lot easier because they're mainly dealing with the parents, and the child copes well at the time. So I said, what is the hardest age to treat? And she said, age 18 to 21. Because between those ages, you're hoping to leave home, you're hoping to go to college or near university, you're trying to separate yourself from your parents, and suddenly you might have to go home. You might have to be cared for by your mother again. And that's very bad psychologically for young people. They cope very badly with it and they tend to react badly, you know. And I, for one, was quite a rebellious patient. You know, if they said you can't go on holiday, I'd go on holiday without insurance on my own to a hot country for 2 weeks, you know. So I really was dreadfully difficult to deal with at the age of 21. And she kind of highlighted why that was. I also learned that I had missed out on the great chemo. So my chemo was in 1987, but in the 1990s, they developed BCOP, which is still used today, much better, much more effective, much better tolerated. And that kind of was a bit, oh, if only I'd got it 5 years later, I might have not had this effect and this effect. But it was really interesting to hear the scientific point of view. Also, and some of you might not know this, I mean, I'm a nurse, so I'm quite scientific, but histologically, Hodgkin lymphoma was identified by a cell called the Reed-Sternberg cell, and that was identified by a German doctor. So that's kind of why the symposium took place in Cologne in Germany. And we had a most interesting talk from a very, very good man called Dr. Deal, I think Diehl, and his colleague Peter Borchman. And Dr. Deal was known by the Americans as the Hodgkin's doctor. And he started working on Hodgkin's disease in 1968. And by 1994, they realized that it wasn't a disease, it actually was a cancer. It was a monoclonal B-cell lymphoma, and it was renamed Hodgkin lymphoma. And I just want to quote something because I found something that he actually said on the evening. But this is what this guy said. So in 1968, his vision was to unlock the mystery of the Reed-Sternberg cell. He had a dream that one day young patients would survive. 54 years later, visions and dreams are a reality. My message to the new generation of clinicians was never to stop dreaming or having visions. Keep working hard. What a guy. Amazing. Absolutely amazing. I also met Dr. Kevin Effinger, who was so kind and gentle. And I know lots of you have met him and have been to see him in his clinical practice. And I was quite disappointed to hear that he was retiring. The professor that I went out to Germany with, he spoke quite a lot because he and his department, together with various other departments in Europe and worldwide, are starting to think about how to follow up patients. And they've come to realize that bringing people into their clinic room once a year and asking them, are you all right? And the patient says, yes, I'm fine, is a waste of money. So they're all in their different ways developing information technology to develop apps or websites to follow patients up. And in Manchester, in the north of England, they're developing a program called ADAPT. And basically, they do 5 years of follow-up after your treatment. And then you're passed on to this ADAPT program. You see a clinical nurse specialist once, and then she adapts you to this personalized website. So all your details are on there, all the things that are likely to happen to you in the future are on there, and the telephone numbers to ring should you get certain symptoms, when to phone your GP or when to phone the hospital. But one thing struck me as I walked around the posters in the exhibition hall one evening, and lots of doctors are displaying posters because they all want their names on posters. That's how they get their PhDs and stuff. That there are several hospitals in Europe doing this. There was an Australian model for an app to do this. Why there isn't worldwide collaboration, I do not know. I mean, Hodgkin lymphoma is not that common. I mean, it's common enough, but there's no, with today's technology and databases, why they can't collaborate, I do not know. And that kind of annoyed me a little bit, because if they can't collaborate on websites and apps, you know, they can just about collaborate on treatment. They ought to really get their act together. And that was about it. That's about all I have to say. But if anyone wants to ask me anything, please go ahead. Nice to talk to you.
Oh, Louise, thank you so much. That was great. I have to say, I'm sure I'm not alone. I was close to shedding a few tears when you talked about how difficult it can be and how lonely it can be. And I think you hit the nail on the head with so many of the feelings you've had about having been a Hodgkin survivor for so long. So I'm going to let people raise their hand, and everybody can show your video. Maybe keep yourself muted until we get you to ask the question, but we certainly want to see everyone's faces now. Louise, I also want to just say, I don't know if this relates to what you were just talking about, but you had mentioned to me something about working on a patient portal. Is that what you had just mentioned?
Yeah, that's the Adapt. It's the Adapt. So I have helped them with their website.
Okay.
And the weirdest, I mean, I was fairly critical, because why not? And one of the things that I criticized, they had a chameleon up in the corner. Their symbol was a chameleon. And I thought, I just don't identify with a chameleon. What has a chameleon got to do with, why not have I mean, the Reed Sternberg cell, that identifies as an owl. Why don't we have an owl? At least the owl is wise. All a chameleon can do is change its skin. I'm not changing my skin.
I hear you. If anyone has a question, do I have control of your video? I hope not. Let me just, if you have a question, you can put it in the chat, or you can raise your hand. I think there's a way to do that with a little emoji, but I didn't realize I had control. Rachel, if you're there, hi, David. You can unmute, I think.
No, I was just saying thank you. Yeah, you had control of the video. I couldn't turn it on.
Oh my goodness. I don't want to do that. Oh, Paul, I see.
Wonderful presentation. That was awesome.
Yeah. Paul, I just see your question about Dr. Effinger. Is that, am I saying it correctly, Effinger or Effinger?
I don't know.
Yeah,
it's Effinger.
I had him, but he was my doctor at Sloan Kettering. I was there actually when Paul was there for a long time. So I was depressed that he went to Duke. That was not good. But to hear that he might be retiring is devastating. That's the first time I heard that. I don't know, but have you heard that, Paul?
It has been a rumor for a couple years now, and I keep confronting him about it. Obviously with the passing of his wife, he does love to spend time with his grandkids. We know the time is eventually going to come, and I'm telling you, he and I had this conversation that we made a deal back at Sloan Kettering, that he was going to make sure that I got to see the day that I had grandchildren. So I keep reminding him we have unfinished business to do. He's not allowed to retire until that happens. I'm not wishing my 17-year-old or 20-year-old to make me a grandfather yet. They've got a college that I want them to get through. But he does explain that, and he has a clinical trial going right now. And of course he travels the world, educating as much as he can. So he's harder to see, but that man still makes himself available to all of us. And, if you don't have a direct line to him, if you know somebody who deals with him, we can act as the go-between, and he's still going to answer. He's a dynamite guy. He really is.
He's been very dedicated to long-term survivorship, and Hodgkin's folks in particular. Paul, would you agree with that? I mean, that's kind of been a area of expertise for him. That's been my experience. That
what I was shocked when I started at Sloan Kettering with him, his bio. Okay. I had heard so much about Dr. Effinger from Linda Zame and, and all this stuff. And I figured him to have, this amazing title, but his title was family clinician or something like that. It wasn't even anything to do with oncology, but as you read his biography, and I probably will say this wrongly, when he started at Texas, he had been studying Hodgkin's at that point, and this is why, the possibility of retirement may be real. He at the time had been studying Hodgkin's lymphoma and its effects for 35 years. And that was 12, 13 years ago when I started seeing him.
Yeah. So for those of you who may not have heard his name, he is a well-known physician and researcher in long-term survivorship. He has a lot to do with the St. Jude long-term study on children's cancer survivorship. He's known to many of us who've had him in the United States. He does a lot of speaking. He was our speaker of choice for the first conference we tried to do 3 or 4 years ago. And I pray that we can get him for the next one, which I'm hoping is going to be in June of 2024. In fact, if any of you have seen our post about this or on our website, we put out a survey. We're hoping to have our gathering in June of 2024. We had posted the date of June 14th to 16th. We realized that's Father's Day weekend. That's maybe a conflict for many of you. We don't want it to be. The reason that we did that was because we didn't want to back up to the ASCO, American Society for Clinical Oncology, their clinical meetings, which is once a year, which is the end of May, beginning of June. So we may have to, and because in the past, that was a reason to have difficulty getting speakers for us. And we do want to have some folks in this area come talk while we're all together. Excuse me. So we may be changing the date, going back to the June 7th time. Nothing is set in stone right now. The date, the location, we'd like to do it in Boston again, but we're open to other ideas if that doesn't work out. We just really, really want to take a stab at doing this again. In the past couple of years, it has not felt safe to do it. I honestly have no idea if it's going to be safe in June of 2024, but fingers crossed in the next year and a half, it will be. And as Paul and I were talking before, maybe with Rachel as well, to not try to do it, to me, feels worse than giving it a try. We need to meet in person. We need to be there together. And it will be very tough for a lot of people. We realize that. We intend to do some serious fundraising to offset costs for this event so that we can make it possible for people to come. And that would include lowered hotel rates. I don't know what we can do about travel expenses, but our mission is to find some heavy duty organizations and maybe drug companies that would generously donate to us so that we can pull this off. So we're not going about it with the idea that everyone can just pull money out of a piggy bank and say, okay, I'm off to Boston. We know that that's tough. So, but we really want to try, and I hope that it's my dream in my lifetime to make it happen. And as Louise has so poignantly and emotionally pointed out, who knows when that's going to be? I think the talk we really need to have is how scary it is to be possibly facing a shorter lifespan. And that's a very daunting thing to confront. And I think, Louise, you did such a great job of giving voice to that. And I hope that the clinicians who heard you really took that to heart, because I think it's something that we don't talk about enough. It's something that's not really studied or researched, but it is very much a part of our journey. And I hate using that word because it's overused, but that's what it is. And on the same, before I'll shut up now, let everybody else talk, but one of the things that Hodgkin's International is kind of hell-bent to do is to give voice to exactly these kinds of things. And what we've discovered, and I've been to a lot of these research conferences, is that, you know, studying long-term survivorship isn't sexy. Putting money into long-term survivorship isn't profitable. You know, so we're not being called upon to participate in research studies. They're studying drugs that cure cancer. I want that too. I very much want that. However, I don't want those of us who have suffered from cancer's cure to be forgotten. And that is our reality. And unless we jump up and down and say as much as we can to people who will listen, that's not going to change. Even though there's, you know, 20 million people out there who are potential cancer survivors, it's not going to be the focus of attention unless we make it so. There's just not enough people who are willing to make it a priority. They are, you know, physician's assistants and primary care physicians are stretched so thin, they couldn't possibly know everything there is to know about what we're dealing with and what people coming across them on a, you know, daily basis are dealing with. So it can't be any one person's problem. It's got to be all of us. And we are working so hard on trying to come up with ideas, on sharing our voices, on working with other organizations to say, listen, we're here, we can help. Just, you know, include us in the conversation. So with that little spiel, I'm sure some of you have questions for Louise. Last thing I want to say is that, and that is what I just said, is exactly why doing what Louise did is heroic in my book. It's not easy, but if you can get brave enough to stand up in front of a group of who, much less 3,000, that's progress as far as we're concerned. So take it from Louise. She's alive to tell the story. She got through it and came out in one piece and then some. And hopefully somebody heard that. And we say that in this group a lot. If we can save one life by sharing what we know, then what we do is all worth it. I'll be, happy the rest of my life if I know that's a possibility. And we are working hard to make sure that it is. And okay, I'm done. Who else is ready to spiel? Raise your hand, jump in there, unmute. Carla, you have to unmute. You're muted.
So I have a question for Louise. It's very general. I really was intrigued by the diaries and all the interest in the young men, because I was only 16 when I was diagnosed, 17 when I was treated with mantle radiation, confronted with all the possibilities of the late effects at that time. They really didn't know, but all these horrible things could happen, including infertility. And so what it really resonated with me, that you were paying attention to all these young men, and you weren't really interested in with your treatment, but affected so much by that treatment. And I often think that all those things, even though I have a great capacity for denial, and denial really helped me be healthy at some parts of my life, I really think that affects decisions you make, important decisions about your life. Or for me anyway, it did. And I was wondering if you could speak to that a little bit with your experience.
Absolutely. So as soon as I qualified as a nurse, I was cured in the same week, or cured, I finished my treatment. A little bit optimistic. Actually, I was cured, but I didn't know that at the time. And I left London and got a job by the seaside as a nurse, working at a holiday camp called Butlins, which is a very famous English holiday resort full of, well, it's just, you don't need to know what it's like, but not a good place really, but great fun for a young person. And I met a guy within a few weeks and I fell in love and I married him because I just had to do everything really quickly. I thought,
Yeah.
And I thought, I just rushed at everything. I thought I was going to be left on the shelf. I was 23 years old. I had no idea that I'd still be here. At 57, I could marry at any time. But at that moment, I said, let's get married. Let's do this for our honeymoon. Let's buy a house. Rushing. And I think that is absolutely an effect of the treatment, the diagnosis. It's kind of a denial, but it's also a impulsivity that a lot of people that I know that have had Hodgkin's did the same thing. Some people were a bit more sensible, but the vast majority of people I know rushed at it all.
Yeah.
Because you just don't know how long you've got. And I suppose I still am a bit like that, I still want to do everything very quickly and get it done. I don't delay things ever. Apart from learning to drive, I delayed that by about 30 years.
I see a lot of nodding of heads. Does anyone else want to jump in there and say how they are all feeling too shy? I was like, oh, go ahead, Rachel.
I just want to say thank you, Louise. You're the first person who I've met who's talked about like that overwhelming urgency to do everything once you get done with treatment. I was absolutely like that. And I, at 25, and I was making all sorts of hurry up decisions that in the end, I look back and go, whoa.
Same here.
So it was interesting to hear you say that. I was like, oh my gosh, that was me.
I love hearing you talk about the boys part, because I was 15 and I was totally into, the blonde haired guy in the basketball team. And my whole mission was to figure out, how to get him to ask me out. I couldn't care less about the fact that I was throwing up from chemotherapy every day. I figured that was a non-issue, but didn't forget the fact that I looked like hell. But I was determined. I think it was a great distraction. I'm not even sure I would call it denial. I just think it was a lovely distraction. And I think we need those in our lives.
Yeah.
And Carla,
my diaries, a pharmacist came onto the ward. Oh, he's so good looking. I really like the pharmacist. Oh, there's a new doctor. I've got a new So he's so this and he's so sweet, or he's so nice, and he came and sat on my bed, and I was in hospital at one time because I had septicemia and pneumonia and all sorts. Just a nightmare for 6 weeks, a 6-week stretch, and I became institutionalized very easily, and I'm just in love with everybody wearing trousers.
This could be a book. I'm just curious how many of you, I know there's a lot of parents out there who were dealing with their diagnosis or maybe their late effects at a time when they're also raising kids and can't really call that a distraction. I mean, my kids were pretty young when I had things like open heart surgery, and that was tough. But I also try to imagine, having the cancer treatments with young kids, and that would be tough. Paul, do you want to? I see your hand is up, and maybe someone else too has that experience of raising young kids when you were sick. Go ahead, unmute, Paul.
You've actually hit a couple points, Louise, as well. I'll never forget my rude introduction into long-term survivorship. when I had my widowmaker. Totally unaware. You saw my post. Some saw my post from earlier about my friend who got her 5-year goodbye. From her oncologist. Don't have a care in the world. She happened to be my campaign manager when I ran for school board. She also witnessed many of the long-term issues that I have had to deal with. So I was kind of really shocked that she's like, okay, I'm out of here. Don't need to worry. He's just said, just get some blood work every year. But for my kids, they were 8 and 10 at the time, the first trip to the hospital they saw for me. Not really understanding it. They're now 20, well, going to be 20 next month, and the other one's turning 18. They finally were told about the surgeries themselves when I had my valve done a year ago and my carotid stent before that. When they come right now, I do talk to them a bit more in detail so that they understand how serious this has been for me. Unfortunately, they've been given a totally different version from their mother that, dad's okay. There's nothing wrong with him. He's tough. He goes through this, he comes back and whatever else. And, as Louise points out, we know that's not always the case. I have a conversation going with Josephine recently, as difficult as it is for her to hear. Louise, like you said, we know we're not going to be here forever. I know that the 3 heart surgeries that I have, the bypass, the valve, the stent in my carotid, are all going to have to be done again. And to have to face the possibility of a surgery that's already risky for us once, higher risk the second time around. Louise, I told Josephine, I said, I don't know that I'm going to go through it. I said, part of it's out of respect to her because of her unique situation with her son dying as a result of effects from chemotherapy for Hodgkin's lymphoma. We have a very interesting story between the two of us. And Aaron, you pointed out about Dr. Effinger, he tells the truth, as whether we want to hear it or not, whether we understand it. I remember approaching him just when Josephine's son died. He died at 24, 3 months after he got done with his chemo. The adriamycin, he happened to be the 5% that had issues with adriamycin. Nobody was watching him. There was no protocol for the 2D ultrasounds that would have picked it up on the first dose. They allowed him to go through the whole treatment. He had a scan set up, I think, a month later, but by then everything had gone rapidly downhill. And I remember it's one of the few times that I was really kind of emotional, upset-wise with Dr. Effinger. And I said, I just don't understand it, because I've done the research when I talked to him about it. I said, all they needed to do was a 2D ultrasound on this kid. And unfortunately, Dr. Effinger's response was, he goes, it's not cost effective to do this on every Hodgkin's patient, every cycle that they go through for the chemotherapy, even though that 2D ultrasound will pick up the damage developing and you can go to a different treatment. This kid never got that chance. And in the end, of course, he passed. They tried to save him. They put a pump, and he wasn't eligible for a heart transplant. But in the end, it cost $2 million instead of a couple $100 ultrasound. But, that's like you said, this is where the concentration is, making people aware, informing them. We're not going to necessarily change protocols, but people have to, yeah.
Paul, you raise a good point, because this is part of the ongoing issue, is when we say we want you to address our late effects, we want you to carefully follow our cardiac issues. We want you to be proactive about that. That means that doctors may have to order an echocardiogram, proactively. And then do insurances pay for that? Does insurance pay for an breast MRI as opposed to a regular mammogram? You know, that's part of the conversation. It's not just what we need, but who's going to pay for it, and is it cost effective? Now, I would argue that a simple echocardiogram is a lot less expensive than open heart surgery. That, you know, as is a MRI as opposed to bilateral mastectomies or, you know, 4 years of treatment for breast cancer. To me, that seems like a slam dunk. But those conversations are not, they're beginning to happen, but they're not set in stone yet. And I think that's where we, you know, will continue to fall into the cracks. David, did you want to say something about that? Yeah.
I do. And Paul, I'm so sorry to hear that. And I find that your story is just incredible to me at the rate at which I've been, just personally, getting 2D echoes, especially this past year and 2 years. I find it incredible that they wouldn't do that up front or before starting treatment. And I do take that back. And I don't know how many of you have cardio-oncologists. I always have to bring it up because cardio-oncology, I still think, is underutilized across the country. You know, Dr. Tochi's been on here and she's a huge advocate. She's trying to build up cardio-oncology programs at other hospitals around the Chicagoland area. And, you know, my regular cardiologist these past 2 years, I've been on a pretty slow decline. And my voice actually sounded like Aaron's up until Christmas and even maybe 2 weeks ago. Over Christmas week, Dr. Tochi, my cardio-oncologist, finally took over my diuretic program, and I lost 21 pounds of fluid in a week. 8 pounds in one day. That was packing on my legs and abdomen, in lungs. You know, I had consequently been walking around with oxygen and concentrators and you know, they were trying to figure things out. I see a pulmonologist and all of that, you know, and the whole time they're sending me in for echoes, stress, et cetera, et cetera. When it's now, I'm not cured. I just had another stent put in my widowmaker as well, a second one actually, and they did a double. So they went in both my arm and my neck to test the heart pressure, and I've been diagnosed with cardiomyopathy. Where my cardiologist, and here's where my point is, my cardiologist has been adamant that I've got constrictive pericarditis, that I'm having a constriction problem. And my cardio-oncologist has been saying, no, you have a stiff heart, you have a restriction problem. And finally, when they went in and did this catheterization, probably a year late, and I was down to about 150, well, it was back up to 180 pounds of fluid. My dry weight now, it's about 160. And I'm a 200-pound guy normally. But this final cath revealed this cardiomyopathy. So my point is that regular cardiologists will do what they know and stay in their lanes, whereas the cardio-oncologists understand the effects. And I've learned a lot through Hodgkin's International about radiations, fibrosis, and that's why she sent me to the pulmonologist. And so we've now actually transitioned. I just saw the heart failure specialist for the first time, and now going to the clinic, and I'm about to start the process of heart transplant evaluation. Am I even a candidate? So, you know, to hear that they wouldn't do a simple test or a simple 2D echo is just shows me a lack of understanding of the general issue that we all, I think, now see and know and understand as survivors and advocate for, which is why, Louise, you going to that symposium and speaking in front of 3,000 clinicians and letting them know what you go through and what you're going through and what you continue to go through. We're in a marathon. This isn't a foot race. And we have, I learned so much on each of these calls. And the only thing I can do is share what I learned along the way, because I'm trying to pack rat and compile as much information. Had I known what I know now 2 years ago, I wouldn't have suffered these past 2 years of this fluid excess that I've been carrying around. And my new favorite little blue pill is metolazone. I swear to God, that stuff, and now I almost don't even need metolazone. The Bumex and the diuretics are doing what they're supposed to do. So anyway, I just want to say that, all of our stories are so intertwined and so integral to each other that this kind of sharing is huge.
Huge. You're so right. One of the things I was struck by, Louise and David just reminded me of this, that I wanted to ask you. I am shocked and sad that you were the first patient or survivor. I mean, that just kind of says it all. And I, as I say, I've been to a lot of these research conferences in the past couple of years online, and they do have patients, breast cancer patients who represent diversity and need, to be a part of clinical trials. They have those kinds of folks speak all the time. They don't have long-term survivors. It's like they waved a hand at us and say, bless you, but we're moving on. And I want to ask one other question, but before I know some folks have to go right at 2. I want to acknowledge a couple people in the room. One would be Parsley. I see Parsley. And this is our group adoptive dog. We see him online, and he is, and I think I can say, literally a lifesaver, right? And I want to recognize Natasha from France. She has written me a couple of times and brought up the very important idea about how to collect ideas and recommendations from other survivors. And Rachel and I have been talking about how to do that. We're about to switch to a new website, and we're going to try to find ways to fit that in. So thank you. And I don't know, Maria, are you still there? I see your name, but not your photo. I wanted to give a shout. Oh, here she comes. Okay. I don't know if Maria's name is familiar to anybody, and I hate to embarrass you this way, but I'm going to do it. Maria is our guardian angel of fundraising, and she was the person who made a significant gift to us this year. And coming from a fellow survivor, it has just rocked my world, and I can't thank you enough. And I think we all owe you a thank you, but it gives us the chance to do more things like this and beat on more doors and make our voice heard. And that we've been blessed by many donations from people who are here today. I just have to give a special thanks to Maria, because that was awesome. So thank you. Thank you so much. Oh, I can't hear you. You can unmute you.
Oh, I thought I unmuted myself. No, I was saying it was my privilege and my honor to support you and all the survivors, because what you do for all of us is just unbelievable, as everybody's been saying. So the thanks really go to you and to all of us, all of us survivors.
Yeah, we're lucky. We're lucky that we found each other. So Paul, just one more quick question to you to circle back to this issue of Josephine's life. How long ago was it that he passed away?
He passed on January 6th of 2014.
Oh, so it wasn't that long ago, 8 years ago. Yeah, David, you're right. I was going to say, I'll give a pass to the doctors if this was 20 or 30 years ago, but 8 years ago, I don't know. Yeah.
And that's what made me crazy, because my friend, campaign manager, she was treated 5 years ago. So only 2 years after he was treated, and to have an oncologist say, well, you're good after 5 years, just tell your primary care doctor to order some blood work every year. No, how about giving her the list of the stuff she needs to follow up on? Dr. Effinger at Sloan Kettering, Aaron, I know you got that same follow-up guideline. Every so many years, you get a DEXA scan. Every so many years, you get an echo, pulmonary function test, whatever. That's what you give a doctor. You don't say, just get some blood work every year and you're going to be good. My Hodgkin's was never picked up with blood work. That's a stupid thing to say. So yeah, I'll get off my soapbox.
No, that's okay. We need more soap.
Stay on it.
I don't know if Tess and Carla, are you still there? I see your names, but not your gorgeous faces. I wanted to introduce, you've probably met them before, but Tess and Carla are fellow board members of Hodgkin's International. Tess has done a lot of writing for us for the website, as has Carla. And you all need to know, there she is.
Yeah.
So I turned my video off.
That's okay. That's okay. We are I shouldn't say we're a motley group, but we're a very small group who all work as volunteers. I work as a volunteer. Rachel takes a very small salary. So we do that on purpose so that we can, do more for all of you. We're not here to be, to be oligarchs of Hodgkin's disease. We are just here because we love what we do, and we, owe it to each other to keep doing it. So, but it's good to point out the faces of folks who are behind the scenes, and there are 3 here, and all of you who have, been to these meetings, Catherine and Susan, and the 2 Susans, certainly Bruce and David. I feel like we've known each other forever. So it's really nice. It's nice to be together, and we thank you for hanging in there with us. And so it's just about 2:00, and if we can, I told Louise we try to keep it to an hour and let everybody get on with their day, but we'll do this again soon. Thanks to all for being here. A special thank you to Louise for being brave and doing what she did and then telling us all about it. I feel totally inspired, and I hope that the rest of you do as well. So thanks again for coming. We have recorded this, and we'll be making it available to all later today, probably. Okay.